Hi, I'm Dr. Rhett Polka from 180 Physical Therapy, and today's video is going to be geared more towards the medical professional. What we're going to do today is walk through what it looks like to do a follow-up visit with a patient using the 180 system and hopefully shed some light on our thought process and why it's so different than the conventional PT thought process and treatment strategy. So hopefully if you're a medical professional that's looking at taking one of our courses and wants more information, whether you're a physical therapist, you're an athletic trainer, you're a chiropractor, you're a physician's assistant, this gives you a better idea of what we do. And by all means, if you have questions at the end of this, feel free to email us. So here we go. First thing we do is history and intake, and what we want to do is cover how that patient's been doing since the last treatment. This really isn't all that different than any other initial process with any other physical therapy visit. So not a lot different here. The one thing that does stand out with us though is that we do not want to focus on pain. So we want to know how the patient's doing, if they have pain, what exacerbates it, if the home exercise program that we gave them previously helped with pain, that kind of stuff. But we don't want to get so hung up on pain that we forget about function, because our purpose at 180 is to return patients to normal function and not just cover up symptoms and get rid of pain. What we'll do on the class when we go through that is we get down to talking about root cause analysis and critical thinking and why it's different as a thought process to treat the root cause versus just going after pain, symptoms, swelling, lack of range of motion, weakness, that kind of stuff. So after we get some information from the patient, what we do is go directly into our functional screen. So our functional screen is basically our baseline and our pretest, and this is what we want to come back to at the end of the treatment to make sure that we pass the post-test. So our functional screen focuses on what we call the kinetic matrix, which is we're screening everything in the body. We're doing it in a functional pattern. We're doing it in weight bearing. We're taking shoes off, braces off, tape off, anything that's a symptom modifier, we're taking that away so we can see how these patients focus functionally without any assistance. Much different to assess the kinetic matrix with a functional screen than it is to just go look at passive range of motion, put somebody on a table, look at motion, poke around, look at swelling, take girth measurements, that kind of stuff. We want to focus once again on function. After we go through our standard functional screen, looking at the kinetic matrix, we can then break that down into more patient-specific. Whether they're an athlete, we can do a sport-specific functional screen, ADL-specific with anybody who's, we've got a grandma who can't bend over and pick up her grandkids, or if we've got a work comp patient, we can break that down and look at more of their work-specific activities. The thing that we're really looking at in the functional screen is that patient's ability to load and unload or pronate and supinate. We're looking at that in an aplanar fashion, and we're focusing a lot on the transverse plane. So when we get to the recipe for injury, one of the main ingredients for the recipe for injury is inability to stabilize in the transverse plane. This will bring those instabilities out. After our functional screen kind of sets the table, we then go to our NFTs, which are neuromuscular facilitation tests, which is what we have one of our patents pending on. So NFTs versus manual muscle tests. Manual muscle tests are graded. NFTs are pass-fail. So we're not assessing gross strength. What we're actually assessing is neuromuscular inhibition. So these are neuromuscular tests that are muscle-specific. We have a test for every muscle, and some muscles we have several tests for because they have multiple heads. So we can test every single muscle. When we go through our functional screen, what we're going to do is look at what positions they fail in. If they fail in a position here, when we go here, that's already set the table for our thought process to let us know where we need to start assessing our neuromuscular facilitation tests. This is going to be part of our treatment. As you'll see, we don't treat anything with modalities. Everything we do treatment-wise is hands-on manual therapy. So once we assess and we'll assess one muscle at a time or one head of a muscle at a time. If we assess a muscle and it fails, which means that it doesn't contract on time, it doesn't contract with enough force, or it can't sustain a contraction, then what we do is say that muscle has neuromuscular inhibition and we need to treat it. That takes us to our manual therapy. So, our manual therapy is also one of the things we're patent pending on, and what we're doing here is treating that neuromuscular junction and the muscle spindle. In order to do that, we have to go to certain points on the muscle belly, and basically we're doing manual therapy on those points, and that's what reestablishes the normal neuromuscular facilitation. Notice that I said that we're going to the muscle spindle specifically. We're not going to the origin and insertion of the muscle because that's where the GTO would be. And GTO, as you will learn in our review of physiology, the GTO is not both afferent and efferent. Muscle spindle is. That's why we treat muscle spindle. And you really need to know your anatomy in order to get through our manual therapy portion. And that's why we spend a ton of time reviewing anatomy. When we have third-year PT students come do their rotations with us, they leave saying that was the most intense anatomy review that I've ever had. Because we have a test for every muscle and every head of every muscle. That means we have a palpation for every single one of those, which means you're going to learn how to palpate every muscle there is. Once we palpate the muscle, we want to go back and test our work and make sure that we actually did that correctly. So what we do is we go back and we reassess that same NFT that failed. So now that NFT should pass, we should have normal, good contraction. If we repeatedly test that muscle, it should stay strong. Once we've gone through this process several times, we might have somebody come in that we test 55 muscles on and we treat 35 of them. After we get through that whole process of treating and testing, then what we want to do is go back and once again prove our work. And after we get through that process, we're going to go back to our functional screen and reassess our functional screen. So let's say that we had somebody coming in for knee pain. They said their pain is much better, but they still have a little bit of patellofemoral syndrome when they descend stairs. We do the functional screen. They can't pass the single leg squat test on the involved leg because they cannot tolerate pronation. They can't load and unload. So what that does is sets the table for when I put that person on the table, I'm already thinking I'm going to test and I'm going to be looking at abductor hallucis, soleus, gluteus medius, vastus lateralis, gluteus maximus, contralateral lat, and pyramidalis. So if I put them on the table, I run through all that stuff, and that just because I'm thinking that doesn't mean that that's what I'm going to find, because nobody's the same and this is not a protocol. I get through that, I come back, I redo their single leg squat test, and now they can control pronation, they pronate normally, they supinate normally, they have no pain, they have normal stability, and they say, I feel fantastic. That means I probably did a great job and I actually got all this stuff correct, and now they can function, which is the important part. After our functional screen, the second time, then we go to patient education. So throughout this whole process, we're educating patients and telling them this is what we're looking for, this is why we're different than the physical therapist that you went to before, the chiropractor that you went to, the massage therapist, the personal trainer, whatever they were doing before. We want them to have a great understanding of what we're doing and the science of what we're doing, and our patients that really understand what's going on, I would say have a fantastic grasp of anatomy, physiology, and biomechanics just from understanding what's going on with their situation. So throughout the process, we're educating them. We want to make sure when we get to the end of the treatment that they understand exactly what we did. We want them to know why they got there. A lot of the people that come to see us are coming to see us because they caused their own problem, because they got poor advice, whether that was from the internet, a personal trainer, another physical therapist, whatever it was. What we tell patients is 50% of the reason why you're here is because you were doing something wrong, and once you stop doing that, you've already fixed 50% of the problem. We'll fix the other 50% for you. So we also want them to have a great understanding of the law of reciprocal inhibition, which is really, really, really what our base is built on. So if somebody's coming in with tight hamstrings, we want them to understand why they should never stretch their hamstrings, why they should never foam roll their hamstrings, why they shouldn't get a massage, because although that might take away their hamstring tightness for the short term, it doesn't assess and treat the root cause of their problem, and the root cause is the law of reciprocal inhibition. So we want them to understand when we give them a chair crunch to facilitate abs, that's what's treating their hamstring tightness. We also want them to understand the progression to injury. A lot of physical therapists, chiropractors, massage therapists jump into the end of the progression to injury and treat the symptoms, whether that's tightness, swelling, instability, gross weakness. That's not the problem. Remember, we're treating neuromuscular junctions. We're treating this patient as a neurologic patient. So once they understand that if you get to the beginning of the progression to injury and treat that, all those symptoms that come down the line are now gone and won't come back. After patient education, we then go to home exercise program, which is a basic functional reinforcement of what we just did with all of this treatment. So we talk a lot about function, but none of this stuff that we did here is functional. So if we reestablish normal neuromuscular facilitation, they've got full range of motion on the table, they can pass all of our tests, and we just send them home without any kind of functional reinforcement, we really haven't fixed anything, because their body is going to want to fight to be the way it was. Their body thinks that the mechanics that they've been using and the movement patterns that they've been using are correct, and that's what they're going to fall back into. So what we want to do is get them off the table, run them through a home exercise program, whether it's reviewing what we gave them before or updating that program. And the home exercise programs are never corrective exercises. Corrective exercises don't exist, and you can have patients try to do these till they're blue in the face and they're not going to work, because corrective exercises cause more compensation because they don't reverse neuromuscular inhibition. Once you reverse that, then you can give patients corrective exercises. They're no longer corrective exercises, they're just functional reinforcement. If you try to give somebody an exercise for a muscle that's inhibited, all they can do and all their body is able to do, because that's the way it's made, is compensate differently. So once again, we're training mechanics. We don't modify symptoms. We don't tell them if it hurts, put on tape. If it hurts, if your plantar fasciitis hurts, put an orthotic in your shoe, because that promotes dysfunction. And if they still have pain, swelling, lack of range of motion, that means we still need to work on this stuff up here. We want them to understand what the recipe for injury is, and if they don't put those ingredients together, they can't have the recipe for injury. And one of the ingredients for the recipe for injury is neuromuscular inhibition. So if they understand why they should not stretch, foam roll, massage, wear orthotics, then they should be staying away from most of the ingredients that go in the recipe for injury. So that's what it looks like in a quick overview of what we do. You can tell that there's a lot of anatomy, physiology, biomechanics that go into this, and that's what really sets us apart from typical PT thought process. So this is an actual system that we use, and this is all we use. If you take a look at our treatment room, we have a table. We don't have modalities, we don't have tape, we don't put people on decompression tables, we don't treat symptoms. So what our classes do is allow the students that take it to become an expert. They're an expert in anatomy because we're going to review everything and make sure you know all of your anatomy and you know how to palpate it and treat it. You're going to have to understand physiology because you're going to have to explain this stuff to patients. And the way you know somebody is an expert at something is ask them to explain it. So if you can go through and explain our system to a patient, you have to be an expert on anatomy, physiology, and biomechanics. So you're going to have to understand when somebody comes in for tension headaches why you're still taking their shoes off and assessing their feet on a functional screen. You're going to have to understand that when you have somebody that can't control pronation in a single leg squat and they have patellofemoral problems, it's more likely because of the vastus lateralis, and the vastus medialis oblique has nothing to do with it. Once you're an expert, you can prove your purpose. And remember, our purpose is to restore normal function. Thinking critically is something that we will go over extensively in this course. We'll have an entire section on critical thinking and what it's like to go through the wheel, how you apply that to your evaluation and treatment, and what it's like to get to the root cause analysis and not just get stuck treating symptoms visit after visit after visit. we've had a big push, and there's been a big push in evidence-based practice ever since I got out of physical therapy school. But when it's time for the rubber to meet the road, we as a profession don't do a great job of looking at the literature and using what we find in the literature. So this course will allow you to actually be an evidence-based practice expert. And we apply all of the anatomy and physiology aspects that you learned in school, but you never were taught how to put them together. So when we teach anatomy and physiology, we're not teaching you anything that you haven't learned before. The important thing is we're teaching you how to apply that to the clinical setting and understand why what we've done as physical therapists for so long was not really the best thing to do with these patients. So hopefully that sheds some light on what we're doing with our continuing ed classes. And if you are a physical therapist, athletic trainer, physical therapy assistant, chiropractor, physician's assistant, and you're looking for something to change the way you treat, this is not a tool for your toolbox. You're not going to take this and then go also do a bunch of other stuff that's out there continuing ed-wise. You're going to take this, and this is going to be the tool that smashes your toolbox and replaces the old thought processes and really sets you apart from everybody else that's out there. Once again, if you have questions, shoot them to us and we'll do our best to get back to them. Until then, think different, live well.